which is quite an honor, but you also feel humble, because if you see what has been done since 2006, the book, everybody knows the book, most people have the book, most people still have it wrapped in plastic, but some of them actually have read it and implemented it. So it's very important to discuss these things, have these meetings, and keep the dream alive, but also execute on the dream. So today we're going to talk about how do we create value in diabetes. In this case it's type 1 diabetes, so not to confuse with type 2. Just to educate a little bit, Netherlands, 18 million people. We have around 1 million, 1.2 million people with diabetes. 10% of them have type 1. So we have around 100,000 people with type 1 in the Netherlands. And most of those patients are being diagnosed at an early age. It does have to be an early age. You can also be 36 or 40 and you get diagnosed, but most of these patients are diagnosed at an early age. So this is a little bit of the breakdown. This working? Would be good if this works. Yes, thank you. These were headlines from last year in the Netherlands. And actually these headlines say that people with type 1 diabetes live on average 13 years less than people that do not have type 1 diabetes. So if your child, 5 or 6, gets diagnosed with leukemia, the chances that this child is diagnosed with leukemia, the survival rates are better than the child with the same age with type 1 diabetes, just to give you kind of an atmosphere of what the disease is. When you look at the complications and the things that people have to manage with type 1 diabetes, they live 13 years less. The divorce rate of parents with children with type 1 diabetes is 100% higher. Productivity is lower. Absence of school performance is lower. So type 1 children have less chance to get an education or a better job, and we can go on and go on and go on. There are actually 3 phases in the disease. That's the onset. So, if you're lucky, you go to the GP and you manage that there's something wrong. In this case, mostly with a child. If you are unlucky, you go with sirens to the hospital and you get admitted to the ER. That's the onset. The second phase is that you need to deal with your disease. We'll talk about that later, but that means that you are, for life, until now, you have to deal with that disease. So you need to be managing your disease by yourself. 336 days, you need to do it by yourself. The other days you get help from nurses or physicians, but it's mostly something that you need to manage by yourself. You go by puberty. If you have children in puberty, you know how their hormones go. There are 42 factors, not only food, that influence your hormones and also that behavior. And then in the late phase, you get the secondary complications. There's also the early death, as mentioned. This is data actually showing, the amount of patients that are affected. And on I think the presentation got a little bit mixed up, but you can see that there's the age cohorts, and you can see that there are bubbles that actually are, describing the amount of costs, but also the onset of the disease. And you can see the blue ones, it's eye problems. After 5 or 10 years, patients already have eye problems. After 10 years, there are already the first signatures of kidney problems start. This is data actually retrieved from a big insurance company, where the CEO is also here, from Zilveren Kruis. So this is a collaboration between Diabeter and Zilveren Kruis, where we actually looked at the claims data, our outcome data, and actually we have also a publication on this. So the essence of this is that you need to manage your glucose well, because otherwise you end up with all these kinds of microvascular complications, which will drive costs, but also influence patient outcomes. If you look at the macro complications, the macrovascular complications, stroke, myocardial infarct, these are, describing the incidence of myocardial infarction, strokes over the years. And you can actually see that the curve flattens a little bit down, so the incidence goes down over time, but still, type 1 patients in the end face massive chances of myocardial infarction. If you are diagnosed at 2 years old and you're 42, the chances of having a myocardial infarct are 9 times bigger than people that do not have type 1. same for stroke. So there's a lot of outcomes that we can improve, but with type 1, it's the secondary complications that we need to prevent. So the microvascular complications, but also the macrovascular complications. And in 40 years' time, it has improved, but not to an extent that we can actually prevent that. So there's a massive amount of value that we can create. What do we do? Fred mentioned it. We measure blood glucose. You know, we used to do that with strips. Now, luckily, there are sensors and automatic systems that measure that. And glucose is not actually an outcome. It's a surrogate outcome because it predicts everything that can happen in a patient's life. So quality of life, but also the secondary complications, hospital admissions, everything is tied to the measurement and the management of blood glucose. So you need to maintain that into certain levels, which a normal person goes automatically by a pancreas, but type 1 patients do not have that function anymore, so they need to manage that. If you look at costs, we did an extensive analysis in literature, but also against with claims data. Annual cost invoiced for this group of patients, 100,000 approximately, directly to insurance companies is 500 million. If you look at, you know, the cost associated with it, you know, absence of leave, welfare costs, it's around 1 billion. And if you calculate and capitalize the loss of life, 13 years, it's another 1 billion. So 100,000 patients in the Netherlands, average costs is around 2.5 billion euros, which is huge. So on the outcome side, there is massive improvement that we can realize. And on the cost side, which goes hand in hand with the outcomes, there's also massive improvements. These are some pictures from my clinic. I represent the Diabeter clinics. I'm the sole board member of the clinics. We have 5 clinics. They all look the same. They don't look like a hospital. It's a very child-friendly environment because 16 years ago we started off as a pediatrician clinic. Now we treat everybody between 0 and 100. But this is how it is. And especially when you see here, you see a round table. Very important, because the round table represents how we deal with our patients. We sit around the table with our patients. So everybody can look on the screen. The patients, usually also the parents, need to come, especially the father and the mother, because that impacts the outcome of the treatment, and the doctor or the nurse who's sitting around the table. We also have our wall of fame. These are pictures of children. You cannot see them, but they agreed to be on the wall because they have maintained certain threshold of their blood glucose measurement. And then they're so proud that they want to be on the wall, and everybody can see that they are doing well. I think that's a very important thing to highlight. If you've done the course, you know that this is the value agenda of Porter, but this is actually how Diabeter is organized. And actually we tick all the boxes. Proudly to say, but we do. The first one is, yes, we are an IPU. We're an integrated practice unit. We're a standalone clinic of 5. Also, we're abroad, so we have clinics in Saudi Arabia and Spain as well, and going to Scandinavia as well. But we're organized like a Formula 1 pit stop. And again, you know, the example is, of course, sports. But the patient in this case is the car. The car comes into the pit, and there is a team of people, professionals, and they know to do exactly their task in a very short time. Very efficient. And the car and the patient only needs to come into the pit when it's needed. And when it's not needed, you know, it can drive around the circuit and the patient can be at home. And it's multidisciplinary. So we have dietitians, pediatricians, we have psychological care, we have people that, you know, are social workers. All this is integrated into our clinic. So when the patient actually needs to come to the clinic, they see everybody at once in one day. Not have to come back for the other disciplines. Everything is organized into that system. All our care pathways are supported by IT. So every decision that we make, every decision that is being triggered will be logged and will be monitored and supported by data. This is a complex slide, but this is actually an agenda showing glucose data. We retrieve automatically from all the devices that we use, from all suppliers. Automatically we retrieve the data, and it's been filed into our data system. We call it VCare. It's a system that actually automatically retrieves with, of course, support of the patient. And we monitor the patients. By algorithms, we can predict when patients are going to fall off the cliff, are going to be too high or too low. And when these patients are doing well, it's a good discussion. It could be remote. But if these patients are not doing well, we contact them or we bring them into the clinic. This is data that the patient can see on his app, on his application, on his phone. And we have that data also in our clinics. When COVID struck, and I saw the presentation of Maurice, in one day, we had all the physicians and caregivers at home because we already implemented this. And we could continue the care to our patients remotely. And we monitor the outcomes on a daily basis. And we didn't see a decline, we actually see an improvement in outcomes. We measured 250 parameters per day per patient. So our database is extensive, not only glucose data, but also quality data, clinical data. We measure a lot, and we have all that data present. If you look at outcomes, again, you see here the outcome scale, which in this is, how well are these patients in range in blood glucose. And you see here different age cohorts. And the worst performers, in this case, big study done with, I think, around 300,000 patients across Europe, only 15% of the worst performers managed their glucose in range. In this cohort, 9% and 21% for above 25 years. The best performers do 46, 50, or 53% reach their targets. Diabeter at this moment, this is the latest data, we are above 60% now, managing our patients in range, which has consequences for quality of life and which has consequences for the cost. This is 222, 223. Again, maybe complex slide, but the bottom until orange, I'm colorblind, so I think it's orange.
Yep, it's orange.
It's orange. That's where you want to be, because that's below 7.5. And you can see gradually over the years, Diabeter has performed the benchmark above, under 7.5 and above 10 and 14, which are really outliers. We have decreased that. This is what we do on a daily basis. This is what I discuss with my team as a whole organization, and this is what the doctors get on a monthly basis, not to judge them, but to see how they're doing individually and compare what they can learn from each other. So this is the culture that we have in Diabeter, to constantly be transparent on what outcomes we have, but also to challenge our internal organization to every year get better and better, because that's what we do. This is a study international, 500,000 patients in the different cohorts, again, under 15 to 24, above 25, we are top 5 or top 1. This is not to show, oh, we're so good, but this is to show that we constantly are interested, how can we improve? The Netherlands, in that sense, is interesting because there is no data about type 1 diabetes outcomes in the Netherlands. There are some hospitals that share that voluntarily, but the Netherlands is the only country, compared to all these other European countries, that are not obliged to share outcome data on type 1 diabetes. So when here was mentioned in the panel, yeah, we need to compare and we need to know what kind of data there is. We also have to make sure that these kind of data are being transparent, so the patient can choose where he needs to go, the insurance companies know where to buy, and that we can compare between our caregivers as well. So this is my choice, is only to compare with international benchmarks. We also measure costs, so we measure costs structurally. We know the cost of our care delivery, we know our productivity, and on average we are treating 3 to 4 times as much patients as the average in the Dutch hospitals. So our knowledge business case is quite positive, because we only do type 1, which means we have a lot of knowledge about that disease, but also our productivity is much larger than hospitals, which makes us, in that sense, also from a knowledge point, I think, a better advantage. Porter says you need to move to bundled payments. For me, that's not a goal in itself. What we wanted to do is that, okay, we perform quite good in the Netherlands, and of course I'm biased, but the data shows I do. But I actually get paid in the same way as all the other providers. So what we did is, with Zilveren Kruis, which is represented here in the room, but also it's the largest health insurance company in the Netherlands, with almost 30% market share, we sat down and said, okay, how do we change actually this? How can we actually get paid for the value that we deliver? And the contracts that we have now are quite transactional. You know, we negotiate 6 months, we celebrate for 3 months, and then the whole circus starts again. And actually, we do not have any incentive to do better than our peers. So what we did is we sat down with the insurance company and said, what's the ambition? And the ambition is that we want to have a complicated-free life for our patients. And of course, we want to do that also at minimal costs. And that's not, you know, per se the driver of an insurance company to lower the cost, because they're very much interested in quality. So that was our shared ambition. And then we said, okay, what kind of outcomes do we want to reach? So we set outcomes on, you know, quality of life and simple parameters as glucose, but we also said, how do we actually, you know, incentivize those? But also, we wanted to have integral responsibility for the patient. So we want to have the space to do what's possible for our patients and an insurance company to back us up, which they did. 1 year, again, is transactional. It doesn't make sense, because diabetes is a long life disease. It's a chronic disease. So if you want to measure year by year, it's difficult. The complications come after 10 or 15 years. So we also said, you know, we want to improve, but we want to have commitment. So we did it for quite unique for 10 years, which is unique in the Netherlands, but it's also unique in the world. So this is the first 10-year outcome data agreement that we have with an insurance company. But also to perform and to see what we do, we needed to compare. So we have the third party, you know, comparing our outcome data with the claims data of the insurance company and combining that. For us, as a relatively small, you know, healthcare provider, that's quite, you know, a leap of faith, because, you know, insurance companies talk about billions and we talk about millions. And if something goes off, you know, that's a leap of faith. So we also built into the agreement that there's a kind of safeguard. If something really goes off the road, you know, we have a discussion. And I think that's the most important part. Because we were sitting down, and this is not a process of 1 month, this actually took us 18 months, 18, to get this agreement done. We started out at 2 sides of the table, and in the end we were sitting around a round table discussing how can we actually manage this. And I think this is a great example, actually probably for me the only example, how you can actually construct these kind of agreements. You need to sit around the table, get all the biases and all the opinions out of the room, and actually look at what's important, and then that's outcomes. And if you can manage that, you know, I get questions, what's the most important part of driving this? I think for me it's getting, you know, they're not different tables, there should be only one table. And in that sense, the insurance companies really chipped in and actually helped drive this. Because without the insurance companies, it's not going to fly. So we had this agreement, which we proudly signed already in 2018. So we're now actually 5 years down the road. And yes, we have lived up to the expectations. Yes, we have lived up to the agreement. We actually outperformed the contract or the agreement. So everything is, in that sense, is very positive. And this is, you know, the schematic thing, of course. You have the different DRGs. Yes, we still invoice the DRGs. But we actually looked at what's the total cost of treating a type 1 diabetes patient. So we calculated, you know, the average cost. And then we said, this is something that we're going to compare every year and see how we do towards, you know, the average in the Netherlands. And of course, then there's the shared savings model, and if you do better, you know, you get a better pay. Again, you know, this is the scheme that we used. We had targets on outcomes, we had targets on costs. If you outperform the outcomes and if you outperform the costs, in this sense lower them, then there's better financial results, and that's being rewarded into a contract. We can do this because we can calculate per patient, per day, what the trend is of their glucose management. And we can actually compromise that into 1 page. So actually I can, on a daily basis, I can go to the insurance companies and can say, well, this is my trend for the whole population, which gives an incentive of how well I'm doing. And of course you can go much deeper, but that more or less is the essence of the contract. The next step is, and I'm almost ready, is what we call cloud care. Because in the end, now there's a generation. I have 2 daughters, they're 14 and 16, and if I say, can you give me my mobile phone? It says, why do you say mobile phone? It's a phone. Yeah. But that's the reality. They do everything on their phone. And a large cohort of our patients is young, and they don't want to go to the clinic. they want to do this remote. And also, as described by Peter, the biggest challenge, and also by Maurice, in the system at the moment, is the shortage of staff. If you ask a manager of a hospital, what are your 5 problems? He says, staff, 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 and staff. That's the problem. So also in Diabeter, we're lucky that a lot of doctors and nurses want to work at our company, but also we have staff problems because I have waiting lists, which I think is unacceptable. So I have another problem. And in that sense, cloud care is a way of treating these patients remotely. So all the data generated into one system is monitored, which you could call a kind of Eurocontrol, which monitors all the flight patterns in Europe. And when a plane is too high or too low, it gets adjusted remotely. And when there's something wrong, you bring in the plane to an airport, which could be, in this case, a clinic. That's very metaphorically, described how we run our cloud care program. We have implemented this in the Netherlands 3 years ago. We're running that actually in Spain. In Barcelona, we have 2 big children hospitals where we actually triage and run their pediatrician clinics remotely. And also we have a clinic now in Saudi Arabia and expanding on that as well. And this is a physical clinic. So, and lastly, you asked me what kind of developments is. We're going to take care of the whole population. I say, quote unquote, whole population of Iceland, which is 350,000 people. They have around 1,500 type 1 diabetes patients. And we're going to monitor them remotely because the hospital is lacking staff and doctors to actually do it quite well. A requirement for that is that they have technical solutions, which means sensors and insulin pumps. But in Iceland, 95% of all type 1 patients have a sensor and an insulin pump. So that's quite easy for us to do that. And this is just giving you a highlight of where the future goes. My doctors always scream, I'm busy, I'm busy, I'm busy. Now I'm implementing this, and now they're screaming, is this going to take over my job? So now I got a whole other challenge internally. So we need to balance that as well. And I liked your slide where you said, don't bring in the technology. You need to build a team that actually wants to implement this. Because our biggest challenge is that we have around 5,000 patients now, but there is, another 95,000 patients in the Netherlands that we could treat. And honestly, if you look at the outcomes of some hospitals, I think we better bring them into Diabeter and not keep them in the hospitals. Hospitalizations ratios in the Netherlands average 6 to 8%. My hospitalizations ratios, that means bringing your child to an ICU or bringing them to the hospital with sirens, is less than 1%. If you translate that already into short-term outcomes and costs, that's a massive impact that we have on patients' lives. So with that, I have one quote for you. This is, we're also on the World Economic Forum, and we are a leading example for that, and we also presented on the G20, and this is actually Silver Kruis presenting in Saudi Arabia on the G20, so quite proud on that as well. This is the 2 founders that we already referred to, Henk and Henk-Jan, the 2 pediatricians. They are now with pension, and luckily they are. But they're still, consulting on a daily basis on how to drive the engine of Diabeter further. So I'm very happy to have them on board. And this is my last quote, which I think I stole from the Martini Clinic, but I don't care. But if you read this for 1 minute, what we're doing here, I said 10 years, Fred. It's not new, because this quote is already from 1860. So with that, I will conclude my presentation. Thank you very much.